So in the interest of time, I'll get started as we have a great presentation to get to. Welcome to today's Age Well webinar. My name is Alison Schneider, and I'm the Education and Training Manager at Age Well, Canada's Aging and Technology Network. In today's Age Well session, Assistive Technologies in Long-Term Care, Insights and Experiences, we will explore assistive technologies and their potential for supporting care in long-term care homes and discuss the facilitators and the barriers associated with their implementation. We're excited to have three speakers for this session today. Joining us is Danny Sinden, the Director, Center of Excellence and Research Operations at Perley Health. We have Dr. Miro Jaina, full professor and research fellow at the University of Ottawa. And we have Daniel Cruz, a research assistant at Perley Health and a PhD student at the University of Ottawa. This panel plans to speak for about 45 or 50 minutes today, and then we'll have a Q&A session to follow. So please post any questions or comments for the Q&A either in the chat box or in the Q&A box at any time, and we'll get to those at the end of the presentation. You may also raise your hand to ask a question verbally during that Q&A session. All of those boxes, the chat, the Q&A, raising your hand, as well as closed captioning, they're all on your Zoom toolbar. So look there for any of those assistive features of Zoom. Okay. So this webinar is being recorded and will be available for replay on the Age Well members intranet, which is available only to Age Well members, or will be posted on our Age Well YouTube site. Okay, so without further ado, I will invite our speakers to kick off their presentations.
Danny, to give you some background and context about the projects and Perley Health. To you, Dania.
Thanks, Miro. So we have a growing aging population with increased life expectancy. Older adults are at higher risk of developing chronic diseases, and therefore the need and demand for long-term care homes which provide 24-hour nursing and personal care is increasing. And within the long-term care environment, health information technologies present opportunities to support staff, residents, and their families. And this can be done through improving efficiency, reducing the healthcare professionals' workload, improving care coordination, and residents' access to timely healthcare services. However, long-term care homes do lag significantly behind other areas in healthcare in relation to the adoption of health IT, and they face significant challenges with the adoption and implementation. So some of these challenges might be caused by the longstanding issues in the long-term care sector, such as the lack of funding that homes have to pay for these technologies, the complexity of resident needs, and challenges with the design of IT solutions, among other things. Next slide, please, Danny. So today we're going to be focusing on a specific type of technologies called assistive technologies, which are particularly relevant for the long-term care environment, as they have the potential to reduce costs, help compensate for the shortage of healthcare professionals in long-term care, and at the same time support the quality of life of older adults. And so assistive technologies are really a broad category of technologies, but the literature has defined and classified it into the 5 groups shown on the screen. So for our presentation, we're going to be focusing on the 3 technologies that are highlighted in the pink box. So social interaction technologies are the devices that aim to provide meaningful engagement for residents in long-term care. And these could be things like tablets and smartphones. And then there's also assistive technology devices, which are the hardware and software applications that are used to support and enhance a person with completing different tasks. And then finally, assistive products are those that can help to maintain or improve a person's functional capabilities. So later on in the presentation, we'll be describing a technology that fits each of these categories. But I'm going to pass it to Danny to describe a little bit of the setting where we implemented each of these technologies.
Thanks, Danielle. Hi, everyone. So the technologies that we're talking about today are ones that we've implemented at Perley Health. So Perley Health is a community of care located in Ottawa. It's home to over 600 seniors and veterans. We have long-term care and seniors living, as well as a number of specialized programs and services on site. We've got 450 long-term care beds, which are spread across 3 interconnected residents, including 1 residence that is dedicated to veterans. The average age of our residents is 85, but we have residents that range in age from 23 to 106. We also have over 850 staff working at Perley Health. So the mission at Perley Health is to be a leader in innovation and frailty-informed care to enable seniors and veterans to live life to the fullest. And one of the ways that we do that is through the creation of a Center of Excellence in Frailty-Informed Care, which was established about 5 years ago. So the COE, as you can see, is based on 3 pillars that all feed into one another and are really stronger when they work in synergy, where each one is really informing the other. So the research that we do is driven by the care that we provide and the opportunities that we see in our environment to find new and better ways of doing things. And the goal is really to share what we learn with others through our knowledge translation pillar. Our goal is to help lead and facilitate changes and improvements in practice in long-term care for older adults living with frailty at Perley Health, but also beyond the walls of Perley Health. So before I move on to the technology projects that we're going to be talking about today, I just wanted to provide a little bit of context and history about how this collaboration came to be, because I think it's really unique and really demonstrates the value of co-designing research between healthcare organizations and researchers. So a few years ago, as the COE, or the Center of Excellence, was being established, we were often getting approached by IT companies with solutions that they wanted us to test and trial. And at the time, we really weren't well prepared to deal with these requests. We didn't have processes in place to guide our decision-making, and oftentimes it sort of felt like putting a square peg in a round hole, like the solution wasn't really quite fitting our context. And that could be quite overwhelming, not only to myself, but to the staff and the frontline staff and managers that I was bringing these solutions to. So Miru and I were looking for ways to collaborate together. We had done a few projects together, and we were looking for new ways to develop knowledge in the area of IT adoption, specifically in long-term care. And I was explaining the challenge that we have, that we're innovative, we want to test and adopt technology, but we don't really have a good way of assessing these opportunities. So we thought a good place to start was to look at the factors that go into decision-making when it comes to IT adoption from the healthcare organization's perspective. And this is how it really all started, was through a master's thesis project, which Danielle led, our co-presenter, who focused on the decision-making factors for managers in long-term care when it comes to IT adoption. So this turned out to be an extremely relevant and applicable topic that's not only helped me structure how I think about these opportunities, but will be of great use to other long-term care homes as they face their own adoption challenges. And Danielle will be talking about that in a little bit. So moving on to talk about the technologies we'll be discussing today. They are all very different, and each one really had a different goal when we set out on each of the projects. So the first one was the ARM device, which stands for Ambulation and Retraining Mobility Mechanism. So this is an assistive mobility device that aims to support residents and staff during ambulation and has the potential to reduce falls and the need for additional support from staff. Our research, however, didn't focus on these outcomes in particular, but really the purpose was to pilot the device and understand how the ARM device could be integrated into the workflow of physiotherapy sessions with residents and to assess the impacts and challenges in the context of long-term care. So it was really more about the process of implementation rather than the outcomes of using the device. The second one that we'll be discussing is called the Magic Table, which is also known as the Tovertoffel. So this is a projector that is on the ceiling that displays interactive games and activities for residents living with dementia and is designed to promote social engagement. The technology was selected based on a clear need that we had at Perley Health, which was identified through our quality improvement program. We were hearing from residents and families that there needed to be more opportunities for social engagement, specifically for residents living with dementia and those who have communication difficulties, to help reduce social isolation and create opportunities for meaningful activity. And the third one is called Pain Check, and this is an AI-powered software used to identify and evaluate pain. So the technology not only addresses a priority that we had at Perley Health, which is to decrease the proportion of residents who experience pain, but it's a widespread challenge in long-term care, and that is how to accurately assess and manage pain in residents with cognitive impairment who may be unable to verbally express their pain levels. So I'm going to pass it back to Danielle to talk about the factors to consider in IT decision-making.
Thanks, Danny. So as part of my master's thesis, we conducted a Delphi study with a panel of 19 long-term care managers from across Ontario. And so a Delphi study is a methodology that consists of 3 survey rounds and aims to build consensus among participants. So in the first survey round, we had the panelists brainstorm 5 to 10 key factors that they consider to be important in informing their decisions to adopt health IT solutions in long-term care. And then based on that, we coded this list to come up with a consolidated list to send to the participants for the second round. During the second round, we were aiming to narrow down this list of factors. It was about 102 factors that were brainstormed. So we asked participants to rate the items on a 7-point Likert scale, and then we retain items with a rating that of 5 and greater. And then in the final round, we asked participants to rank the remaining items based on their importance, where the top ranking factor was what they considered to be the most important in their decisions to adopt health IT solutions in long-term care. And so based on this round, we had the list of key factors that's just shown on the right-hand side of the screen. So there's 25 in total, and the top 5 are high priority items that managers consider in their decisions to implement technology solutions. So the availability of funding, impact on workload and efficiency, value proposition, ease of use, and the impact on resident outcomes. So I'm going to pass it to Miru to describe a little bit more about each of the technology projects, and then later on we'll describe how these factors played into our selection decisions.
So I'm going to start with the ARM device, but before doing so, I would like to explain that the next 3 slides present the logic models that we developed for these projects. And if you're not familiar with the logic models, these are models or tools that are used to connect the different components of a project or an intervention or a program. And they are very useful to see, to identify the resources going into these projects, the activities that are done, the outputs that come out of them, and with the hope that on the longer term, the goals and the outcomes would be that are anticipated, in this case, improving residents' care, supporting the work of healthcare providers, and so on, would be achieved. So given the timeline of these projects being short, we have some limitation in terms of the ability to report on the outcomes, longer term outcomes of these technologies. However, we'll give you a brief overview of what we have found so far. One of these projects has concluded, which is the ARM project. However, the 2 other projects are still underway. So it's a work in progress, and we will give you an overview of what we've got so far. So for the ARM device, this was a new technology that was being pilot tested in the context of Perley Health. And there was not a lot of benchmark to work with in terms of seeing whether this technology has been tested before, has worked before, and so on. So it was an adventure, an endeavor that Perley Health, as a progressive long-term care home, wanted to embark on. And I think there was a lot of learning that happened in the process. The project involved mostly physiotherapists and physiotherapy assistants who provide support and care for the residents. And to give you a little bit of context, around 300 residents receive physiotherapy care at Perley Health. And the device was supposed to be used in group or individual physiotherapy sessions, with the goal of maybe reducing the human resource burden on the team and providing support during these physiotherapy sessions. I will not go into all the details of the components under the activities, outputs, and outcomes, but I want to emphasize the fact that there has been a lot of work happening in terms of preparing to the implementation of this technology. So several demo sessions were conducted, several training sessions were done, and even after 1 month post-deployment, we realized that the team needed more training, so more training was offered along the way. And at the end of the day, we had 27 residents using the device over a 10-week period, and we conducted observations, workflow mapping, and pre-post implementation surveys to get the input of stakeholders, physiotherapists, physiotherapy assistants, residents, about what they thought of the technology, whether it impacted the workflow, whether it impacted the sessions that they were having. To our surprise, we realized that based on the observations that the session's duration was increased rather than decreased with the technology, which is something we did not expect. However, the need for human resources, like an additional person helping during a physiotherapy session by pushing the wheelchair behind the resident so that if they need to rest, they would rest immediately, was eliminated with the technology. So there were pros and cons emerging from the project, and there was a lot of motivation and momentum towards using this technology pre-implementation. After using it, again, to re-emphasize, it hasn't been tested and piloted really in other settings to have some benchmark to work with. So we had to address some technical problems that were faced in terms of attachments, bolts having to be fixed, attachments needing to be fixed. So I think the motivation for the technology decreased a little bit over time because of the technical problems that they were faced. Although the value of it and the interest was still there, and it was just in relation to the implementation process, the hiccups that we had in the process. So this gives you an idea about one of the projects that is focused on the assistive devices that was deployed. The project wrapped up. We are finalizing the manuscript that will be submitting to a peer-reviewed journal, and it was we'll talk about the lessons learned at the end, but one of the take-home messages from this project was that even though the technology presents value, it's important also that it be reliable and have the least technical challenges to be able to be implemented smoothly within the long-term care environment. I think right now I will pass it to Danny for the magic table.
Yes, thanks, Maru. So I'm going to just talk a little bit about the magic table. So as Maru mentioned, this project is still ongoing. So it's not complete yet, but we can tell you a little bit more what we've experienced so far. So this project, we were fortunate to get funding through the Center for Aging and Brain Health Innovation through the Discover and Adopt program. So we decided to put one magic table in each of our 3 buildings. As I mentioned, we have 3 buildings spread across our campus, as well as one magic table in a central location, which could be accessed easily because 2 of the units that we installed them on were on secure units, so they weren't accessible to everybody. There were other inputs such as the tables themselves where the images get displayed, the chairs and so forth. Plus we had our research team. Early on, we identified several project champions. And actually, just before I talk about that, so I mentioned when I was introducing the technologies that this project was really based off of a need that we were seeing in our environment. So based on the results of our quality of life survey that we administer on an annual basis, social engagement had been identified as a pain point for us. So this was following COVID and people were feeling very socially isolated, and we were actively looking for opportunities to increase opportunities for residents to engage with others and to engage with caregivers. So this was an established pain point, and we made sure to involve staff right from the beginning. So we offered several demonstrations in the home. So we put it in very visible locations where people could see it and interact with it. The nice thing about the magic table is it's very easy to, it's very likable. It's very colorful, it's very interactive, and it's intuitively something that you want to be involved with. So we tried as much as we could to communicate within our community that this was a technology that was coming here, and to get as many people involved and excited about it as we could. So this resulted in us being able to get 128 staff trained. So we implemented a pre-survey, and in order to complete the pre-survey, you needed to have received the training. So that's how we were able to track how many people actually got trained, as well as 24 caregivers. We also completed observations, which are still wrapping up right now, to actually see the magic table in use and to actually see residents interacting with it and collect some information based on those observations. And so in terms of outcomes, again, we're still analyzing the results, but we've already seen increased use. It's been great to expose our staff and caregivers and residents to this type of technology. We've seen engagement and more people taking ownership of using the magic table as part of their role. And we've also heard from staff that it has, in fact, increased quality of life for our residents, which is really the ultimate goal. And I'll just mention the contextual factors that we sort of had to deal with along the way, but being on resident units, we had to be mindful of outbreaks, which may impact the use of the magic table and impact the flow of people onto the units to be able to interact with the technology, as well as some building maintenance issues where we had to actually relocate, or actually the magic table where it had been located wasn't accessible because of some building issues. So those are some things that we had to deal with as the project progressed. So I'll pass it on to Danielle to talk about the final project that we'll be discussing.
Thanks. So our final project that we are discussing is Pain Check, and similar to Magic Table, we received funding through the CABI Discover and Adopt program for this project. And so Pain Check also came out of one of the pain points that Perley Health was facing in relation to residents with pain. And so staff were facing challenges with accurately and reliably assessing pain in residents with cognitive impairment, as sometimes they face challenges self-reporting their pain. And so Perley selected Pain Check to implement in the Gatineau building at Perley Health, which is one of the buildings that cares for residents that do often have higher levels of cognitive impairment and may not be able to self-report their pain. And so we started this pilot project in mid-June, and we're going to be continuing until December to test the solution. And so far, about 3,487 assessments have been completed. So staff are required to assess pain in residents using the Pain Check software at least once per week, and then again on an as-needed basis. And then when the software identifies that the resident is in pain, then the staff will provide an intervention, whether non-pharmacological or pharmacological, and then they will have to reassess that resident within 2 hours. So for this pilot project, it's mainly focused on the registered nurses and the registered practical nurses at this time, as they're the ones that assess pain in residents in long-term care. And so we provided training sessions for them. And then during this time, they completed a pre-survey, which assessed their confidence in measuring pain with residents that have cognitive impairment, and also the current pain practices at Perley Health. And so far, right now, we're starting to conduct the post-surveys, and we did identify some challenges with this project in relation to workflow that we'll discuss a little bit more later. But based on that, we are providing additional training for staff in hopes of increasing use, and also trying to get other groups involved, so physicians involved as well. Next slide, please, Danny. So for the next couple slides, I'll be going through the facilitators and barriers that we face in some of these projects. And so based on the facilitators that we observed, we categorize them based on a systematic review that had different constructs on factors that affect health information technology adoption by older adults. And so I'll be focusing on the ones that we observed across all 3 of the projects today, which are highlighted in the pink boxes on the screen. And so for performance expectancy or the perceived usefulness or benefits of the technologies, this was seen as a facilitator across all three of the projects. And I'll just provide some examples of each. So in the pain check project, in the pre-surveys, the staff identified that they perceived it would help provide a more accurate and reliable assessment of residents' pain. So that really has helped to encourage use. And then for the effort expectancy or the ease of use, across all three technologies, staff perceived in the pre-surveys that the three technologies would be simple and intuitive to use. So in the Magic Table project, it just uses a remote with a clearly labeled power button and then arrow keys to select the different games. So it's perceived as simple for staff to use, and then there was limited effort required for them to learn how to use this. As far as training, you just heard with some of the projects that we provided demo sessions and training for staff across all three projects. And I'd say the training for the Magic Table was probably the most extensive because it was implemented across all of the buildings at Perley Health, whereas the ARM and Pain Check focused on specific areas. And so for the Magic Table, we had 3 days of demo sessions. We trained staff, volunteers, caregivers, and people are still able to sign up on an as needed basis for anyone who's interested in training. So we are still continuing that training. And then looking at the product design. So it's really important that the assistive technologies are developed with the needs of the user in mind. And so all three projects, we've made customizations to the devices to ensure that it's user-friendly for either the staff, residents, or the caregivers to use. So for example, in the case of the ARM project, we added colored tape onto the ARM devices so that residents would know where to grip onto. And that just helped to make it a little bit more user-friendly for them. And then looking at the Magic Table, we started adding, in some of the games, you can add customized images. So that's helped to increase residents' use of the technology, as some of the games are now images of things that they're interested in. Next slide, please, Danny. Perfect. So on the other hand, there was also some barriers that we observed across each of the projects. And one of the things that you'll note is that some of the factors that were facilitators were also barriers experienced within the projects. So looking back at effort expectancy, it was a facilitator, but under some circumstances, it's also a barrier in the projects. So just as an example with the ARM project, there were some challenges with attaching the devices onto the wheelchairs and onto the walkers. So the staff members would have to do that for every session, which added about 5 minutes to each physiotherapy session. So it increased the session time from 15 minutes to 20 minutes, which meant that the physiotherapy assistants could see less residents per day. So that really impacted the project. And then also looking at habit. So in this case, habit refers to the extent that an individual will perform a behavior automatically. And what we've learned is that it really takes time for these technologies to become integrated into staff members' workflow. And so for the Magic Table and the Pain Check project, we haven't seen the technologies fully integrated yet because these projects are still in progress. And the ARM project was only tested for a short period of time, so we also didn't see that get integrated into the staff members' workflow. But one of the things that's important to note in the long-term care sector is that staff have to ensure that they're meeting the direct care needs of the resident first. So in the Magic Tables, a lot of times staff do want to use it and socially engage with the residents. However, time is a barrier to this. And so one of the strategies that we came up with to overcome this is that staff can actually do their charting at the Magic Table, so that they're socially engaging with the resident while also ensuring that their work is done. Next slide, please, Danny. And so on this last slide with the facilitators and barriers, we've just provided a summary of what we've observed across each of the three projects. And so again, you'll notice that some are both facilitators and barriers, such as the costs. So in this case, solutions that have low upfront costs or low ongoing costs, it becomes a facilitator, whereas on the other hand, the high cost, upfront cost to invest in IT solutions can pose as a barrier. And we observe this in the Magic Table, where the table itself, if anyone's looking in the chat, it costs around $16,000. So it's a high upfront cost, but the ongoing or maintenance costs are quite low. You just need batteries for the remote, and then change the bulb and the projector. So it's got quite low ongoing costs, which is a facilitator. And then some of the constructs are just facilitators or barriers that we've seen in the projects. So one of the things that we noticed is that it's really important to have project champions and super users. So in the case of the ARM project, we didn't have any project champions. It was a team of about 8 physiotherapists and physiotherapy assistants. So we didn't think we needed to have a project champion at the time. But what we found when we moved on to the Magic Table project is that project champions and super users are critical for increasing use. So for that project, we recruited 1 nurse and 1 personal support worker for every building and every shift. So we ended up with a total of 49 super users and 23 project champions, which has really helped to encourage the use of the technology. And then there were a number of barriers that we observed across the projects related to health conditions, privacy and security, and interoperability. So in relation to residents' health conditions, their health does fluctuate quite frequently. So it's important to keep this in mind in relation to your expectations for using the technology. So in the ARM project, we had recruited 27 residents, but with their fluctuations in health status, sometimes they weren't mobile and able to walk with the device. So that affected their ability to use it. So I'll pass it on to Danny to discuss some of the strategies that we have for engaging with stakeholders in long-term care.
Thank you. So yeah, these are some of the strategies that we apply to our stakeholder engagement in the context of these projects. So just going a little bit deeper from what Danielle was talking about. So we mentioned we involve frontline staff in the identification of pain points and the review and selection of the technology. So one way that we did this was through demonstrations, and we made sure to involve them right from the beginning. So ideally, we were involving them not after the decision, but was made to take on that technology or to address that pain point, but really make them part of the decision-making team and feel as though they had a say in what we were doing. We also cast a really wide net when it came to who we involved from our stakeholders. So we had people involved from nursing to recreation to support services. We really wanted an all-hands-on-deck approach for the Magic Table project. And we were able to get a lot of support from different departments, which helps with the sustainability of the project. We also identified implementation champions really early on and ensured an ongoing communication with them. So we often talk about tokenism when we're talking about patient engagement, but I think that can also apply to involving staff, frontline staff in these types of projects. So when you're identifying champions, you really need to embrace the concept of the champion and give them the responsibility and ownership throughout the process. So you can do this through regular team meetings and check-ins. These are some of the things that we found that worked well. We also feel and applied the notion that you need a dedicated implementation team, or at the very least, you need release time for people. So thanks to the funding that we received for some of these projects, we were able to do that. But you really need people who are focused on the project and not trying to do it off the side of their desk. We also offered incentives for participation to support the uptake. So this can be anything from gift cards to offering refreshments at the demonstrations. We acknowledge that they are giving up their time to help us make the project stronger, and we wanted to make sure they felt as though their time was valuable. We also sought real-time feedback and made improvements along the way. So we didn't wait until the end of the project. I'll use the Magic Table again as an example, but we didn't wait till the end to implement some of the feedback that we were receiving. And I think this goes a long way in terms of building trust. If the stakeholders can see that there's changes being made as a result of the feedback and their efforts. So again, for the Magic Table, the stakeholders had a say in the type of tables that we purchased. So, making sure that they were adjustable. That was something that we heard was important. Getting feedback on the location of the training materials and the additional materials that go along with the Magic Table. Just getting their feedback and applying that in real time really helped as well. And then involving stakeholders in the actual research. So that having them participate in surveys and focus groups, having their input in terms of the workflow mapping. It's important not to underestimate the value of involving them in the research, getting their input on the surveys and so on, because their input is really only going to make the project even more relevant to this context. And I will pass it over to Nuru to talk about some of the challenges.
Thank you, Danny. So in this last part of the presentation, we're going to be sharing with you some of the challenges and lessons learned in the process of running these 3 projects, and provide some recommendations at the end. So as you can see, the 3 projects had a different angle, different type of technology, category of technology, and different objectives when they were implemented. So like I said earlier, with the ARM project, the project was launched as an innovative new technology that may potentially address human resource constraints. But there was no specific pain point that was being addressed by this particular technology. So unlike the other 2 technologies that kind of rose bottom up from challenges being faced on the floors with residents, the ARM project was seen as an opportunity for improving and supporting the work of physiotherapists and physiotherapy assistants. Like we mentioned earlier, the pain check and magic table projects are still underway. The ARM project has concluded, but from our assessment of sustainability of the 3 projects right now, the ARM projects seem to have had the lowest sustainability. And this is not to undermine the value and merit of the technology, but to emphasize that sometimes the perceived ease of use and the technical issues can play against a technology if they are not addressed promptly and managed immediately. So some of the challenges that we faced with the ARM project were purely technical. And since then, the technology provider has addressed them, came up with a revised model, an updated model of the technology. But when they were being faced, they led to frustrations among the team and some reluctancy to use the technology itself. Danny, if you may please press on the box for the ARM project. Yes, and yes, on this one, the box for the ARM, yeah. And if you can click, just as you can see here, like remember Danielle showed you early on the list of factors that affect the decisions to adopt new technologies. For the ARM project, there were many of the top factors like the impact on residents' outcome, the impact on workload efficiency, the ease of use that were not checked in this particular context. And this may have led or contributed to the lower sustainability of the technology use in this environment. So circling back on those factors, I think it's very important when making a decision about a technology to look into the factors that have been identified by directors, by managers, stakeholders in long-term care homes as important prior to making a decision about a technology that is to be implemented, especially with the limited resources and competing priorities in this environment. Danny, can we go back again? So if we look at the other 2 technologies, the pain check and the magic table, the sustainability of these technologies were a little bit higher than the ARM project, than the ARM technology. And although these particular projects had their own challenges as well, in the case of the pain check, the value was also perceived of using this technology, especially among residents with dementia who are not able to necessarily express the level of pain, and for healthcare providers who may not be able to capture accurately the level of pain among these residents. So the challenge in the case of the pain check technology was how to integrate it in the workflow and work habit of the team. And although it may seem intuitive to scan and to complete surveys, if healthcare professionals have done the assessments in a certain way for a certain period of time, it takes time to adjust and adapt to the new ways of doing work. So in this case, another challenge that we faced was that once the scanning is done and the assessment is done, the place where it's inputted on the point-click care system that is used in the majority of long-term care homes was different than where the nurses and healthcare professionals are used to see it. So just by having the information placed elsewhere in a particular system may disrupt the ability to work with it promptly. So the workflow and habit changes were the key challenges that we observed for the pain check technology. For the last technology, which is the magic table, the sustainability seemed to be high for this technology because really it's intuitive, it's easy to use, and it's spread throughout the home and can be used by different stakeholders, caregivers, informal caregivers, residents, professional caregivers, volunteers, anyone within the long-term care home. The challenge that we faced with the magic table technology was more, as long as it's a benefit, as much as it's a benefit to have different stakeholders benefiting from this technology, it also presents a challenge as to who has the ownership to move forward with the next steps of using the technology. So in this case, Danny, we're going to have to go back to the list again on the next slide. In this case, the magic table was the easiest to use per se in terms of a technology, but again, its impact on workload and efficiency seem not to be very clear for different stakeholders. So is it the part of the role of the personal support workers to use it with a resident, or is it part of the role of the nurses? Anybody can use it, but in theory, who has the responsibility to use it? Who would be able to provide input feedback based on its use with the resident? And these are the type of things that need to be addressed as we move along. So despite the fact that the technologies, all three of them, had perceived value upfront, they were relatively easy to use. Different types of challenges came along the way and may have slowed down the progress of these projects. But like Danny mentioned earlier, adapting and changing continuously has been going on throughout the implementation of these technologies, and this may have contributed to a higher level of sustainability over time in terms of use. Next, please. There are some lessons learned that we took note of as we were working on these three projects. It was mentioned earlier that having dedicated champions is key for the success of these projects. And I think having champions on paper is different than having champions working in practice on promoting the technology, giving you feedback as to what is not working as much as what's working. So it's it's similar to action research, whereby you do small cycles, you implement, you assess, and then you reiterate the process. It's a quality improvement cycle for the IT project as well. So in this case, having champions who voice the concerns, what's not working, what needs to be adjusted, and feeling that they are heard is important, and not just having champions who sign off on the project up front and then you don't hear from them afterward. Technology simplicity is key. Like I mentioned earlier, all three technologies were relatively simple. One of them had technical problems that were addressed in subsequent models, but originally these presented issues and challenges to the project. Integration with point-click care is also essential. For some technologies, it might not be applicable, like, for example, with the ARM technology. This is less applicable than with the pain check technology. But there's something to keep in mind as well, because whenever you're doing assessments of health status, well-being of residents, you want to make sure that the information is integrated with the medical record of that resident. Technology update and integration with the workflow takes time. And as much as we would like to see success and benefits and positive impacts early on, it takes time to institutionalize the change that happens with a new innovation, a new technology. And sometimes having to disrupt or change workflows can have impact on the success of these projects. At the organizational level, visible management support is key, and I applaud Perley Health for always rallying behind those projects, for providing management support, showing like interest in introducing technologies and tools that can help with residents' care, that can help with healthcare professionals' work. So I think that's key. It's different than just bringing in a technology and not seeing that the management is rallying behind it. Shared ownership is important for long-term care sustainability. It's like in most long-term care homes, there's not necessarily like an IT department in those environments, and it's often a group of people providing IT support or a dedicated person providing IT support. So it's very important to have the clinicians, the healthcare professionals, the informal caregivers being involved in the decision making about these technologies and being involved in the implementation and use of these technologies as well for their sustainability. And if there is funding for time release, use it. I know funding is an issue and it's a challenge in long-term care home, but people are working hard. They're putting extra time to care for the residents, to take on shifts. So if there is funding available to release time and let them learn about the technology, use it, help support others to learn about it and use it, it's a really good cause to invest this money in. At the research and operational level, I think I can't say enough about the importance of research partnership with long-term care homes. This is like a critical element of research that we often underestimate or overlook. So I think we live in our towers where we talk about frameworks and theories and models, and then when we go to the field, we realize that there are some particularities of each environment that have to be taken into account that may test or question our assumptions in those models and theories. So partnership is important. And it's important to understand that adaptation and changes in the research approach and in the implementation approach, it's part of the package. So staying agile is key for the success of these projects. And it's not as simple as it seems to introduce a new technology, even if it's a magic table that is intuitive, that's easy to use. But once you see the impacts that it's having and the benefits that it can provide, then I think the team behind it and the long-term care home is gonna be proud and happy of the achievements. We'll move on to the recommendations. Danny will cover the first two parts, and I will conclude with the last two sections.
Okay, so just speaking about from the long-term care home perspective, making sure that the technology that you select is purposeful will lead to better outcomes. So we talked about pain points, making sure that you're selecting your technology based on the pain points that you're seeing in your environment, and use evidence to help dictate these needs wherever you can. So whether this is through data, quality improvement data, clinical data, or through stakeholder engagement is really important, because this is not only going to help with buy-in, but will help lead to better outcomes for the residents. Ensure staff buy-in and project champions, and I mentioned this earlier, but engage your champions early, not just in the technology selection, but having them on board and in agreement with what your pain points are is really important as well. Technology scaling and spreading should be planned early on. So you have to think over the long term, who's going to own it, who's going to be responsible after the implementation team steps back. In the Magic Table project, we hadn't planned for the scaling and spreading of the technology beyond the 4 units. And because some of those units are secure, some of the staff haven't had as much exposure to that. So if we're able to spread it beyond these 4 units, we'll have to think about an implementation and spread plan that's going to meet the needs of the entire organization. For the IT vendors, some of the recommendations, engage and collaborate with the long-term care stakeholders to understand their needs. Ideally, this would be a co-design approach, or at least having the ability to modify the technology along the way according to the needs of the long-term care home is important. Providing implementation support. So be mindful of the specificity of the environment, and this starts with understanding the long-term care environment. It's very different working in a long-term care environment from a staffing perspective, from a resource perspective than other settings. So it's important to understand this going in. And also the other example I'll use is using training materials that are tailored to the long-term care context, thinking about what are the skills of the staff that you're working with, using language that's user-friendly, providing on-demand support, and that type of thing. And then, as Maru mentioned as well, focus on integration with current systems. Consider the roadblocks and feasibility. So, for example, integration with the electronic health record. In an upcoming project, we're learning about the importance of integration with the call bell system. Anything that requires duplication or shadow reporting is going to be a hard sell for staff to get on board with. So these are some of the things for IT vendors to consider. And I'll let Miru talk about policy and research.
Given being mindful of time, I will just briefly point to some of the recommendations at the policy level. I think we have quite a bit of work to do at the policy level in terms of encouraging innovations, adoptions, creating incentives, be it for approvals, streamlined approvals of devices, be it for regulatory incentives for improvement in performance-based incentives, just trying to provide a little bit of support in this sector, establishing credentialing and standardized training in collaboration with universities, colleges, different educational institutions is also key to support the workforce to get on board and also work on considering these technologies and establishing dedicated funding, grants, subsidized for acquisition and maintenance of the technology. These are things to consider. At the research level, I think I spoke a lot about those, but I think like one of the key things I found was relevant to me was to be on site. And again, what we read, what we produce in terms of research, data collection, data analysis, writing of papers, maybe sometimes distant from the environment. So learn about the environment, be immersed in it, and also expect that you're going to go over time in terms of these projects, given the uncertainties and given the nature of the cohort served in long-term care. So this takes us to the conclusion of this presentation. I think the image here shows you that you can think of it as a complicated process, but if you circumvent the labyrinth and then work around it, it can be a relatively straightforward process. It's just a matter of managing the implementation and planning the technology decision early on with the input of stakeholders and with the right planning for long-term care use. Thank you for your attention, and we'll open the floor for the questions.
Thank you so much, Mira, Danielle, and Danny. That was an excellent presentation, obviously, with tons of takeaways for folks. So I expect people will be reviewing the slides because they're really detailed and contained a lot of information really relevant to our researchers here. Okay, so we do have a number of questions. We'll try to get to them all in just a few minutes. So if you could keep your answers relatively short or as appropriate, that would be really great. Okay, so we have a question from Natalie. She was wondering, in the facilitators and barriers slide, were you showing results only for your care staff? If not, what was the level of agreement between residents and staff on each indicator?
So we looked at the facilitators and barriers. It was for staff, residents, caregivers, and their volunteers as well. And there was some agreement, but it's also project dependent. So looking at something like the ARM project, some of the staff originally perceived the technology as easy to use, whereas for residents, it was a little bit more challenging for them to learn how to use, especially in residents that have cognitive impairment. Whereas looking at something like the Magic Table project, it was really important for caregivers to encourage residents to use the technology, and oftentimes they're the ones that are bringing the residents along with volunteers to use the Magic Tables. So I think it depends on which project for that question.
Okay, and you can also follow up with the researchers if you're looking for more detail as well, Natalie. Okay, so lots of questions. So about the Magic Table, one of our participants was asking, did the mood of residents change? And as well, there was a question about the imposition of the added workload. Do you have any comments on that?
I will start, and Danny and Danielle, please jump in. I think we're still in the post stage, like evaluation for the Magic Table, but from what we have observed, I think there is a historic way of doing things in long-term care. For example, the fact that personal support workers are not used to using similar technologies to engage with residents is going to require quite a bit of reminding of like facilitation to change the way they go about providing care for residents. So I think I acknowledge personally the deficit in social programming, and that was mostly also brought to light more and more during the pandemic with the social isolation, with the restrictions that were in place. And this is an example of a technology that can address these deficits. Now, would it add burden? I think not necessarily if it's properly integrated in the workflow for healthcare professionals, but I think Danielle and Danny, you may be able to have a better insight from like the real world environment about this.
I think related to the question about the impacts on the residents and the outcomes there, one of the things we didn't really expect going into this is that the Magic Table has most frequently been used after 6 p.m. So you'd think a tool for social engagement and games would not really be used at night, but from what we've heard from staff so far, impacted residents quite positively in relation to being able to calm them before bed. And it's really good for residents that are experiencing sundowning due to their dementia. So it's been quite helpful what we've heard so far from the staff and the caregivers to have as a tool for them to use at night.
Great, thank you, Danielle. Okay, so we're at 101. Do we have another minute to answer another question from our panelists? Yeah, that's okay. I understand if people are having to leave. I did want to mention to folks before you leave that this group will be presenting at the AgeWell conference this year. So I put that link in the chat if you're at all interested of attending. That's happening in Edmonton at the end of October. Okay, so we just have one more question I wanted to get to because it's quite common actually. And I know you're not frontline staff, but when it comes to evaluating technologies and in which ones you're going to bring into a long-term care center, this person has a question about, Pain Check app and how you can be sure that it's making the right call. So when you're bringing a piece of technology in, how do you assure that it's bringing value? I think that's the concern here. What if it gets it wrong?
I'm going again to start. I think whenever a technology is implemented, it has to be approved and there should be proof of concept, tested. And In this particular technology, there is the scanning part that happens, but also the healthcare professional also answers questions based on the nonverbal cues that or variables that they collect from the resident. So it's not just purely scanning the face of the resident, but also adding answering questions from a healthcare professional perspective, that these two are taken into consideration in the calculation of the pain level. Now, whenever we get questions about, well, do we know if the technology is doing exactly what it's supposed to do? I think it's important to look at the alternative. Were we able to assess pain accurately when we're asking a resident with dementia about their pain level? That's the alternative. So I think if we need to find ways to complement technology with what is being done by healthcare professionals. But in this particular assistive technology, we're going to be able to present the findings of our evaluation soon. But at this point, I think it's not solely based on the scanning. There's also input from healthcare professionals when assessing the pain level. Danielle, Danny, do you want, am I correct in my evaluation of this?
Yeah, I would agree with that, and also just emphasize the importance of involving the clinical team again, especially in the training of this. Emphasizing that the clinical staff who are using this tool still need to use their clinical judgment, and having some clinical oversight in the project is really important too for that quality control.
Thanks so much. Really important to note, technology is there to enhance, right? Not to take away labor necessarily, but to enhance the work that's being done. Okay, so in the interest of time, I'm sorry, I'm going to have to wrap it up. I know there's still some pending questions, but love the engagement. Thanks so much for everyone who was able to attend, who asked questions, and who will take away learning from this great team. So thank you to our three presenters. We really appreciate your time and passing on all of this, these great lessons learned. And if you're able to email or meet up with them at the AgeWell conference, I'm sure you can learn a bit more from this great team. So thanks so much on behalf of AgeWell. I hope you have a great rest of your day.
Thank you.
Bye for now.